This week on the BackTable Podcast.
The low field opens up so many arenas, as Joshua was saying, because not only does it allow us to start looking at tools that were not feasible to come into the MRI environment, but it also means that patients that have hip implants, suddenly that's not as big a problem. So it allows a greater, not only tool selection, but it also allows us to start thinking about those problem patients that either have implants or they have cardiac devices that maybe, or stimulators that we were concerned about. And so now the danger of bringing those devices in is much, much less. And so it opens up our patient possible selection to an even greater variety of patients. The low field is a very intriguing possibility.
Hey everyone, and welcome to the BackTable Innovation Podcast, where you will hear stories from physician entrepreneurs who are helping to drive healthcare forward through medtech innovation.
Hello everybody, welcome to BackTable. I'm your host, Kavi Krishnasamy. I'm an interventional radiologist at UAB, and we have a very interesting and innovative topic today, interventional MRI. I have two guests with me today, Dr. David Woodrum, who's a full professor at Mayo Clinic in Rochester and the director of the Interventional MRI Program. And I have Joshua Krieger, who is the director of product management at Cook Medical. And we're going to talk about everything interventional MRI today. So welcome. Thank you both for being here.
Thank you. Thanks so much.
All right. So I got a lot of topics that I want to cover today, gentlemen. And so I'm really interested to pick your brains on the space, the history of the space, the future of the space. It is a topic that is of significant interest, I think, in the IR community today. So without further ado, let's get started. So David, what is the history of interventional MRI? I know I feel like over the past 10 or 12 years that I've been in practice, there's been some buzz intermittently about it, but where did it start and what has kind of happened to this space over the years?
Yeah, no, that's a fantastic question. You know, historically, interventional MR has been around almost as long as MR in itself. You know, as soon as MR was created, interventionalists were asking, hey, what can we do with this imaging platform? And even as such, early on, 20 years ago, GE was making a magnet potentially designed for interventions. It was called a double donut magnet. And you could actually access the patient in the middle because it had two sets of donuts that it produced the magnetic field and produced the images with. And this was, although unique and very interesting at the time, part of the initial difficulties were that the magnetic environment, most of our tools just did not work well in the magnetic environment. And so there was interest, and a lot of people were doing some very innovative stuff early on. However, because of the lack of tools available to them, it really did not surge forward. And as such, the specialized magnets that were performed or made at the time kind of slowly died out over time. We see that the MRI technology kind of evolved over time into the diagnostic platform that we are all used to seeing today, which is really, you know, that the tube that patient goes through, MR imaging takes place, and then we get the images from those. And it's very similar to a CT, except a little bit longer. So what we have seen historically is that initially IR was done with fluoroscopic guidance. And then over time, we moved into CT guidance for many of our procedures, especially our needle-based procedures and our ablation procedures. And so part of that evolution into the CT was being able to see better where the needle was more accurately. However, we still suffered from not quite the perfect way to visualize whether it was the ice ball or the heating. Now, what we've seen more recently is that we have had manufacturers who are making tools, especially ablation devices, that are MR-compatible. And as such, we've been able to take some of these ablation devices into the MR. And what it has done is really help us realize the true strength of the MR imaging and what it brings to the equation from an interventional radiology position. And that really is that we can target lesions that we just can't see well with CT or ultrasound. The obvious lesions that come to mind are those sub-centimeter liver lesions that we all see. We get calls about, hey, can you hit this? And sometimes you can. Sometimes you're scratching your head and you're going, I think I was in the area, but I'm not 100% sure. Now, the beauty of the MR is that you can see that sub-centimeter lesion and you can see exactly where you're going. And so it can transform a case from, well, I think I got the biopsy of the right place to, yeah, I know I got a biopsy of the right lesion. And so that's a huge piece for targeting. Now, the other piece that MR has been shown to bring to the equation as it has evolved over time is the ability to monitor our ablation changes. And those ablation changes occur with either heating, as we see with microwave, radiofrequency ablation, even some with laser. But on the flip side, we can see the freezing as well, exquisitely well. With the ice ball edge, we can see sub-millimeter kind of resolution on that ice ball edge. And so this allows us, whether it's heating or cooling, to see what's happening in real time when we're ablating. Now, if we've got a big lesion and it's in the middle of the liver, we may not need that kind of precision. But if we have a liver lesion that is on the edge of the liver or in the central area of the liver, then we want to have better visualization. And even outside the liver, whether it's in the kidneys, whether it's down in the pelvis for prostate, that kind of precision adds a huge amount to the equation. Now, why are we seeing it everywhere? Well, part of the problems with the MR have been in the past that it takes a little longer to get there. We haven't seen the tools available. We are seeing an increased growth in those tools. But the other thing is MRs have slowly gotten bigger and bigger bore sizes. And currently, your CT bores are, 70 to 80 cm, while the biggest MR bores have been 70 cm. But we see on the horizon that there's going to be even bigger bores for the MRI. And this allows us the room to intervene on the patients and get the needle. You need the length for getting the needle into the patient and getting both the needle and the patient in the magnet. And that becomes a critical piece. And that's a start. So I would say historically it's been around, but the reason it hasn't gone forward in a bigger way has been the fact that there just hasn't been enough tools to carry the interventional radiology forward on this platform.
Yeah, those are fantastic points, David. And in a lot of ways, I feel like you're speaking directly towards me. The first 5 years of my practice, I didn't actually have access to radioembolization. So thermal ablation kind of is my first love, if you will. And I've only had ultrasound and CT, and there are gaps there, especially as you said, the non-visible lesions, the difficult locations, and we're going to drill down into some of these points as we go through the podcast today. But thank you for that. That was a great answer. So I want to pivot a little bit, Joshua. What is our current state? Where are we right now with interventional MRI that is going to propel us into the future?
Fantastic question. I think I might add one other thing to the last one, and then come back to this. I think one of the things coming at this from a different perspective is that there have been across the last 20, 25 years, 30 years almost, a number of people that have kind of through their own Herculean effort pushed this forward. And what we have seen, and some companies have been involved with that, but what we've seen is that there have been individual physicians who have really strong-armed this into existence in their practice. There have been, as Dr. Woodrum said, some scanner manufacturers in the past who have done dedicated machines. And there have been some some device companies in the past that have made some disposables for this space. But one of the things we haven't seen is all of them talking to each other. There have been kind of pairings of any two of those, but we've not seen that collaboration really across the board. And I think something as we look at the current state of things, we're seeing more of is collaboration. I was at the iMRI symposium here recently, which is an every other year meeting around this topic. And the collaboration across all of the different companies there, all of the different manufacturers of both scanners and devices, and the physicians there was really remarkable. Having been in a couple other spaces doing early stage R&D work, there just seems to be a lot of excitement in this area, and the knowledge that it will take everybody to really bring this about. And so that's really exciting. As we look to current state, there's maybe 30 to 40 sites that we're aware of doing this across US and Europe in a consistent way.
And you're talking, when you say consistent, you are saying not a once a week intervention, you're saying an everyday program, correct?
No, I think the number's a lot smaller when we get to every day. But people who are doing cases on a monthly, on a weekly basis, continuing to push the research forward. Dr. Woodrum, that sounds right to you as far as numbers?
Yeah, no, unfortunately, I think that most sites, we're doing it on a daily basis, but I think many sites are doing it more on a kind of a weekly or every other weekly kind of basis.
Yeah, and they're really, as Dr. Woodrum said, taking those patients where, you've got small lesions not visible under CT or ultrasound, and they need the clinical confidence that MRI can offer to be able to visualize and then target that lesion. We're seeing that on the IR side, pretty strongly around liver and prostate, some general abdominal, and then a little bit on the vascular side around pediatric cardiology, because of, particularly around congenital, because of the complex anatomy and because of the desire to reduce radiation for those young patients. But I would say the majority of what we're seeing is needle-based, because there's a little bit more out there in terms of products for that.
Got it. Okay. Well, that's helpful to know. And obviously the current environment is changing rapidly, also because of the move into low field. So Joshua, can you speak a little bit to low field MR, and what exactly that brings to the table?
Absolutely. So this is something, and I'll maybe just put a caveat out here. If Cook has a 0.55 Tesla magnet and research agreements in place with Siemens, this is an area where Cook is working. If I speak about anything as far as products, please know that it is not a commercially available product and something that is only being used in a research environment. So that's the environment that I come from and the knowledge that I have around the systems. The low field has really, from a device manufacturer standpoint, opened up just incredible possibilities. In the MRI, typically devices are made of either stainless steel or polymer, and stainless steel is a great black cloud of an artifact, and polymer is generally invisible. And so there are ways we can make polymer visible, but the metallic artifacts that are out there are radically reduced in the lower field machines. In addition to that, the heating and the forces on those devices are significantly reduced. And so we can start to incorporate materials back into some of these devices as we build them for that research space that really allow us to have a feel on those devices that is very similar or identical to what you would have in a cath lab, in an angio suite.
And that's because it's low field.
And that is because of the low field. The low field opens up that lower artifact and that lack of heating that really enables that.
So I would like to chime in too on the low field. I think the low field offers a number of strengths. But before I get into those strengths, I would like to point out that the low field also has to meet the imaging rigors that we need, that that is the reason why we came to MRI. And what we have to view with the low field currently is very encouraging on that front. So with that said, as a baseline that we need good quality MR imaging, the low field opens up so many arenas, as Joshua was saying, because not only does it allow us to start looking at tools that were not feasible to come into the environment, in the MRI environment, but it also means that patients that have hip implants, suddenly that's not as big a problem. So it allows a greater, not only tool selection, but it also allows us to start thinking about those problem patients that either have implants or they have cardiac devices that maybe, or stimulators that we were concerned about. And so now the danger of bringing those devices in is much, much less. And so it opens up our patient possible selection to an even greater variety of patients. And so I think the low field is a very intriguing possibility. And the fact that the low field is potentially coming with a, near 80 cm bore is huge. I mean, that's a massive bore for an MR. And so that would give us it gives us the ability to potentially, get all the equipment in and the patient.
Yeah. Yep. No, and that's a great point. And I'll reiterate, this is 0.55T, correct? Which is a stark contrast from the traditional 1.5T interventional MRI suite. So it is a completely different direction. But then also there are other downstream benefits, correct? I mean, there's a lower installation cost. There's a lower maintenance cost. There is no quench. Am I correct in saying that?
So yeah, getting into some of how the magnet is constructed. So first of all, that 80 centimeter bore on the current Freemax is just fantastic for the extra room that it gives. As far as sighting goes, I'll speak to our experience with this. We rolled it on machine skates through a double doors. There was no getting a crane in and opening up the roof. The helium content is less than a liter, as opposed to nearly 1,500 on a typical magnet, although I think we're seeing that more on a wider range of magnets now. But the sighting was just really straightforward.
Yeah, I think the 1.5T systems and what comes with a 1.5 system may not be feasible for the average IR practice, right? But a 0.55T low field system may be feasible. And why?
And the other thing I think to bring out potentially, Joshua, and I think it sounds better coming from you, is that the price point on this, I mean, you're looking at, 1 to 1.5, I think is what they're talking about, which is a price point for a fancy fluoro system.
Yes, absolutely. Absolutely.
And so to your point, Kavi, is, it's no longer way out of range of what IR typically spends for something.
Yeah, I mean, exactly, right? And so it's really kind of opened the doors, I think, for people like myself that have been very interested in this space for a long period of time, and have understood the gaps that are present with just CT and ultrasound. Now we have access to a system like this potentially. Yeah. And that's the exciting part, right? And I know, Joshua, a lot of this is still kind of research capacity. A lot of the devices are still, being looked at in a research capacity. But there are people that are out there that are doing interventions in the low field magnet and successfully and safely. And there is some literature to support it now, correct?
Yeah, absolutely. So kind of coming back to the question around why low field and some attributes of the current magnet that were really attractive. I think ease of sighting is absolutely fantastic. You've got less than a liter of helium fully contained as opposed to a large helium tank. I think some other magnets are now getting that as well at other field strengths. But our magnet was rolled in on machine skates through a set of double doors. It was rolled into place, the room was buttoned up, and we were firing it up shortly thereafter. To be able to, because it's all self-contained, to be able to bring down the magnet to do continued work in the room is a phone call. And it's not, bringing in a truck with additional helium and dealing with all of that. And for us, it was an incredibly high value machine. I think the price point that it comes in at was really competitive, and I think is starting to be in line with some of the nicer angio suites. So really offers siting at a variety of locations. This isn't just for research hospitals. We're seeing this all the way over to OBLs, not just ASCs. So I think it's a really accessible system. And I think that's really important as we talk about these interventions and where they take place, because it's not just research institutes. And I think, Kavi, you currently have a Freemax, correct?
We do. We have a Freemax only for diagnostic capability at the moment. We're trying to retrofit it for interventional capability, which I'm super excited about. But to your point, with utilization of low field magnets, kind of in the space between OBLs, ASCs, it's a huge opportunity across the spectrum of IR spaces that we have, right? Joshua, do you know of anybody in an OBL setting that's doing iMRI interventions or just strictly diagnostic at this point?
We know of a couple folks who are in the OBL setting doing basic needlework. So actually some pain management done by IR.
Wow.
I'm not aware of any biopsy yet.
Okay.
I think, given some plans, I think that's not far off.
Okay. That's exciting to know. I wasn't aware of that. So let's talk a little bit about available devices. And David, I know you kind of alluded to this earlier, or the lack of available devices. Where are we now with? And let's focus on percutaneous devices, biopsy devices, Chiba needles, ablation devices. What do we have available to us in this space?
So we've had ups and downs as far as needles. And let's talk about access needles. So access needles have always been a little bit problematic, but more recently we've encountered some problems, but there's light at the end of the tunnel. And what do I mean by this? Well, In Vivo, which is a smaller company of Philips, was making a full assortment of needles at different sizes as well as biopsy guns. Unfortunately, they've phased out their MR device categories. But now, along with that, ITP, a company out of Germany, has stepped up to the plate and now is also offering a full spectrum of needle sizes and lengths. Now, Cook is now a distributor for ITP here in the U.S., and along those lines, we're excited to see that Cook has now sparked a new division and a new interest in interventional MR tools. So we see that we have MR needles, MR-compatible needles available, but we also see the possibility of a full spectrum of needles that Cook can offer. And we know the quality that Cook brings to that equation. And so we have biopsy guns or biopsy devices that are available, but the devices are not as strong as what we're used to with our standard CT environment. And so we need devices with stronger springs, but you have to do some specialized engineering to get that because the springs are typically stainless steel. And so we look forward to that possibility. I think from an ablation standpoint, it's actually a fantastic landscape out there because in the ablation realm, originally there was, 15, 20 years ago, there was only an RF device, the Rita probes that we all remember that were MR conditional. And so from that, we now have microwave devices that are MR compatible. There's microwave devices by U.S. manufacturers that are MR compatible. The one in the U.S. is typically lower power, 950 megahertz. There is also microwave devices coming out of China now that are MR compatible in the 2.2 gigahertz realm. And so we see a full spectrum of offering, and both of those devices we can do MR temperature mapping with. So the interference is good enough or low enough to where we can actually do temperature mapping to see the active ablation zone with microwave. Now, The other spectrum is laser ablation. Laser ablation, there's a number of laser devices out there. Laser has not been as common in the US. It's more common in Europe, but lasers are inherently MR compatible. And so that's very nice. On the cryo side, right now there's a single manufacturer worldwide that is MR compatible, and that's the Boston Scientific. They bought out the old Galil system, and that system has been a workhorse for many sites around the world. And so the MR compatibility of that system is very good. We do a spectrum of testing on devices that are both, MR compatible, but also looking at devices that are not labeled MR compatible. And it's through a collaboration with our MR physicists that we're able to actually find things off the shelf that sometimes actually work very well within the MR environment. And so some of the wires out there are compatible with MR, and I'm going to pass that baton over to Joshua.
Yeah, there are a couple groups that are offering MR safe or MR conditional wires now. Many of them are, or all of them that I'm aware of that are commercially available are a glass fiber type wire. So you get different mechanical properties with that, but something that is safe. You're not going to have that heating. The challenge with these devices is seeing them well and seeing them in an intuitive way where you can know sufficiently where that device is to navigate it well. And so this is actually where a bunch of our internal work is going right now, balancing those mechanical properties and how we build that up with different materials, with also then visualizing these. And the visualization of these is a little bit different than what you would expect in a fluoro or necessarily in a CT. It's putting marks back in specific places instead of seeing an entire outline quite crisply. But I think we've seen really good use of those markers across a range of devices, both some of the commercial devices that are out there and then in our research settings as well.
Yeah, Joshua, that's a great point. I mean, we've kind of focused a little bit on percutaneous interventions to this point, but there is the whole transvascular side of this. And obviously, I think cardiology and pediatric cardiology are well ahead of IRs in this space as well, right? So I do want to come back to that because I do want to drill into the transvascular side. I think that's another interesting nuance to this space that a lot of IRs really haven't considered. But I want to go back to the percutaneous side here briefly. And this is going to be a two-part question. The current scope of practice in the iMRI space throughout the body, and then the gaps. And I know, David, we already kind of alluded to this a little bit. The gaps that iMRI fills that are present in CT and ultrasound. And I'll state that question with the lens of I'm primarily a CT and ultrasound percutaneous interventionalist, right? I mean, I do a lot of transarterial therapies, obviously, but I do a fair amount of ablation. And I don't have access to an iMRI at this moment. And so I'm used to working around the constraints of CT and ultrasound. Obviously, if the lesion is visible, that makes it very, very easy. If the lesion is non-visible, then I'm targeting based on geographic location. I'm fusing images with some sort of confirmatory type software, pre and post contrast, something like that, or fusing a pre-CT or MRI, which not always the easiest thing to do to get to register appropriately, right? And so, and then that doesn't even get into lesions that are close to other critical structures, lesions, those anterior segment 8 lesions that can be very difficult to target, right? So there are a lot of areas where CT and MRI, has gaps. Then cryoablation, right? I mean, visualizing the edge of the ice ball, I have moved to hydrodissecting much more than I normally would, just because I can see the edge of the ice ball in the hydrodissection fluid, right? You can't see it in the fat. And so all those little techniques that may be obviated with an iMRI system, which is really exciting. So speak to that for me. What is the current scope of practice, and then what can iMRI do that we can't do in CT and ultrasound?
Absolutely. Thank you. So what I would love for IRs to step back for a second and consider is not how we can do the organs better than what we're doing, but also to consider those organs that we're not even tapping into.
Great point.
And the big one, the big one that's in front of us is the prostate. Prostate, the MR is the way that we find cancers in the prostate. And we have a full assortment of focal therapies that we can bring to bear on those cancers. But we do need the MR guidance and the MR monitoring to target and to see what we're doing so that we can do it very precisely. The urologists have been doing prostate ablations and prostate treatments under ultrasound for a long time, and they do it quite well. But where we can bring the difference and step up the equation is by embracing the MR and embracing it in the prostate, which is deep in the pelvis. It is surrounded by structures that we don't want to damage. And to look at that as how, we can expand our practice, expand what we're doing, and expand the realm of treatment possibilities. So I start there. But next, let's think about, again, with the liver. How many liver lesions do you turn away, or you're doing hoops to try to find that liver lesion? You're looking at, where are the portal veins? Where's the hepatic veins? Trying to co-localize this in your head cognitively. If you could just see it, it would be so much easier. And so, but the targeting is only half of the equation. The other half of the equation is seeing what's happening in real time. We talk about the effects of vascularity on our ablation zones. If we can see what's happening in real time, we can account for those changes, and we can make changes in how our needles are distributed so that we don't have to say, oh, this failed because a vessel was right next to us. And so I think we can again take our level of precision up a notch by considering what MRI brings to the equation. And what I've seen is that the MRI also brings to the equation things that we're not thinking about, as far as, can we go after oligometastatic disease in the lymph nodes that may be within the pelvis especially? It's all tight. We've got ureters running through, we've got nerves running through, none of which we really want to take out. If we can go in with MR guidance, we can see the nerve, we can see the ureter, and we can avoid that. We can see the ablation zone so that we can avoid that. And we've seen really good success, especially if we get aggressive with those lymph nodes, so that we have our clinicians calling us immediately. If they see something on a PET scan, hey, call us right away, we'll go after it. Then we can jump ahead, and so I think those are huge opportunities. Now, the other opportunity that is it's something that we're all kind of seeing in a variety of manners within our IR realm, and that's vascular malformations. So the slow flow vascular malformations tend to be resistant to our standard sclerotherapy mechanisms of treatment, but they actually are more sensitive to MR ablative methods of treatment. Whether you freeze them, whether you heat them up with laser or some other mechanism, that works really well for slow flow vascular malformations. And so, but the problem is that many of these are embedded deep in muscles, next to nerves, next to a variety of structures that we just don't want to destroy. And so this is, again, where the MR brings the strength of the equation to the targeting aspects and also to the monitoring aspects. We've also been able to safely do neuromuscular monitoring in the MR environment while we're treating these vascular malformations. And this has allowed us to treat vascular malformations in the brachial plexus and in a variety of very complex places throughout the body. And so those are the kind of details, both in targeting and monitoring, that open up a larger selection of patients that we have been turning away. So if we think about the patients that we're saying, hey, we can't quite get there, we don't see it well enough, those are the patients that we can get with the MRI.
And definitely certain patients that I tend to turn away as well. I totally agree with you. I mean, and I think, let's dissect that a little bit. I think even just the targeting and the kind of real-time evaluation of the therapeutic area, if you will, right? MR gives you real time, right? Which CT does not. And I still run into a lot of people that are uncomfortable with CT dose. And so, and that's, it's an individual decision. I completely understand that. But I have a lot of colleagues that will tend to step in, adjust the needle, step out, get a repeat scan. Whereas I'm all over CT fluoro. Now, I use CT fluoro in a step and shoot format. I don't really use continuous fluoro. And I think that can be done with very low dose to the patient and to the operator when done appropriately. But that is an area of concern, I think, for some IR. So this is a radiation-free, real-time guidance for targeting. And then from a monitoring standpoint, what you're saying is we have real-time monitoring, which in every other modality, there's no CT or ultrasound real-time monitoring that I'm aware of, unless I am unaware of a technology. And so you have real-time monitoring for ablation and for local therapies that we've never had the capability for, right?
Right. You can watch things with ultrasound, but you're never quite sure. You typically are shadowed out by the anterior edge, and you're not sure what's happening on the backside. And that's the problematic aspects of kind of monitoring with ultrasound. With CT, you're not able to see that. And so, once you start getting used to being able to see all that, it starts becoming very addictive.
Yep.
I think a great example of that, just to really make it concrete, is the first case that I saw up there at Mayo, which was cryoablation of a lymph node between the spine, the aorta, the ureter, and the renal artery, which is a tricky spot. And watching the confidence that you were able to have, taking that ice ball, knowing the heat sink properties of those various anatomical structures, walking it up to the ureter, but not into, to ensure that you were getting maximum freeze of that lymph node area, but not, putting this person with a ureteral stent for the rest of their life. I think that was really eye-opening to be able to see that level of confidence and precision around where that therapy is being delivered.
And again, real time, right?
In real time. And I want to touch on the real time because I think this is something that is, well, it has been done. It feels a little bit newer. And the image quality around that feels a little bit newer. And so when we're talking about real time, we're pushing the systems up to, I think I've seen for some lower resolution capable movements, 15 frames a second. I think we're really comfortable in the 5 frame a second, 3 frame a second range. And I wonder, actually, I remember you were working up in the liver, free breathing. I wonder if you could speak to how that real-time navigation down to what was a 5 millimeter target is so different from what you would have in CT and the time frame of that.
Yeah, that's a great question. I think I'm gonna start by saying that I almost never use CT alone in the liver. I will almost always place my probe or my needle with ultrasound into a geographic target, if you will, and then kind of manually adjust with CT. And that's for a variety of reasons, right? It's the way I could avoid the edge of the lung and not cause iatrogenic pneumothorax on the way in. I don't have to worry about breathing as much, right? I'm not asking a sedated patient to hold their breath, which you both know. It's just, you're never going to get the same breath hold, right? It's not even a question.
That's so right. Yeah, even on my lung biopsies, I never talk about breathing because once they think about breathing, it's never the same.
Never the same. And then you just get used to chasing lesions around, right? And I think in the liver, in CT in particular, you also suffer from a lack of contrast resolution and then the added artifact from the metallic needle, right? And so you take literally all of those issues completely out of the equation in the MR scanner, and I can sit there and not worry about radiating my hand as I'm guiding the needle in real time, in a breathing. This was a preclinical model, but in real time towards a lesion of interest or a region of interest, right? And I think that is, I think, what really opened my eyes to the potential here, because I cannot do that in CT. Number one, that efficiently. Number two, that safely. and be that confident in where my needle tip is going. It's just not possible. And so that's I think the eye-opening nuance to iMRI.
Yeah. We went back after one of those. That was one of your first days in the magnet. I think your first day in the magnet in a preclinical model. And the transit time from skin to that 5 millimeter target was about 45 seconds, free breathing in the dome of the liver. The other thing that's, I think, very different than the CT and the ultrasound is because you can visualize the lesion so clearly, you have the ability to take a still image of the needle through the lesion. And so if you're getting a biopsy, if it's a difficult biopsy, you can just take a picture of exactly the tissue that you're pulling out of the magnet, pulling out of the patient. And I wonder if either of you could speak to the way that affects clinical confidence, particularly if it comes back negative.
I would say that is a big piece, because many times if I'm asked by default, if I'm asked to do a biopsy, especially in the liver under MR, it usually has failed ultrasound guided and CT guided biopsy. And so really the clinician needs to know, hey, what is this lesion? And can you give me 100% confidence that whatever the biopsy core is, it's from this lesion? And so I think, to your point, Joshua, is that many times I will try very, very hard to biopsy the trough going through the lesion, just so that when the pathologist comes back and if they say, hey, this is just a liver nodule, that I can tell the clinician, and hey, I was there. This is nothing. This is not cancer. I was there. And so I think that's hugely beneficial. And that's the level of precision that I think we need to shoot for. What MR is bringing to IR is that it's going to allow us to give next level precision care to the patients and our clinicians that we're working for.
Yeah, that's especially true, I think, in an era where genomic sampling is everything, right? I mean, we're biopsying everything we can biopsy. We're biopsying smaller lesions. We're being asked to provide larger or more samples, I should say, for better analysis, and then to just tissue bank for studies and things going into the future, right? And so it's the days where you take one needle pass at a lesion and just want a diagnosis are far in the past at this point, I think, right? So that's Joshua. That's a great question. So here's, I guess, the kicker. Where are we going to be in 5 years, right? And I think from my perspective, and this is purely speculative. So is this a better way to do lung ablation? Is this a better way to do, vertebral body ablation, right? Where we can better monitor, we have real-time ablation confirmation, real-time thermometry with microwave. But where are we going to be in 5 years? Where is this technology going to take us?
I think that one of the things we're seeing is a tremendous amount of interest and a tremendous amount of collaboration. And so I think there's a lot of growth happening in the background. And I think some of those things will be certainly coming into prime time in that 5-year range from a whole range of companies. And I think with that, workflows and the ability to build out these rooms in a way that is not the Herculean effort that some have gone through. So I think making them more accessible and then building higher value to clinical practices. I think that needle work is, that percutaneous work is really closer to prime time. I think as we look at biopsy, injection, aspiration, and then the delivery of therapy, either cryo or thermal, those are the areas where I think in the next 5 years, we're really going to see a tremendous amount of growth. I think the catheter-based work is really interesting. I think it's maybe just a little bit further off because of some of the complexity of visualization, but some really neat things going on there as well. And I think for those patients where it is of even greater value, navigating congenital anatomy, and those patients where radiation is really a significant clinical concern. I think in the next 5 years, we're going to see some neat things happen there as well.
I agree. I think the needle-based arena biopsy, ablations, we have the tools here. I think the thing that's going to change for interventional MR is if we have a magnet that is designed for interventions and it's unveiled in such a way to where those interventions look and feel very much like they do in CT. I think that's the IR easy button. If you know how to do CT, I mean, it's just like you were talking. I mean, you're experienced with ultrasound and CT. If you can walk into the MR and it feels like what you already know, that's great. And I think that's where the collaborative mindset is really helping to potentially move things forward in the more recent realm, is that they're not just trying to make it new and different. We realize that it needs to be easy, both from a user tool standpoint, but also from a user magnet standpoint. And so if we can make it easier to get into the MRI, to do the things we need to do, the reason for doing it will compel, even our most reluctant users to potentially consider doing things in the MRI. So I think we have to reinforce to the manufacturers, both from the magnet and also from the tool standpoint, they need to look and feel like we're already used to them.
From both of you, those are great points. And so where my mind immediately goes is, the old clock trial, right? And you have, as you said earlier, you have 10, 1 centimeter lesions in the liver that are kind of spread all over and difficult to target. And now you can realistically clear that liver of disease and kind of reset that clock for that patient, right? And we know that has a survival benefit from some of those older studies. And now we can adequately do that without spending 6 hours in the CT scanner, which nobody has time to do, right? We have so many other things to do in our day. So those are great points. And I think it'll be exciting to see the evolution over the next several years as people get more and more interested in this space and figure out how to adapt it to their local institution. So with that in mind, how does someone start this service line locally? Joshua, I'll start with you because you've literally started this service line locally, for preclinical models, but yeah.
I might add one thing to the last question, and that is there are some things that I don't think MRI is going to immediately take over. And so as you think about where this is most highly applicable, if you can easily hit a target with ultrasound and you're not doing an ablation where you need to understand sensitive structures, if you're doing an ultrasound biopsy, if you're doing something that is very easily done under CT in a very short amount of time with a low radiation dose, that's not the first places where this is going to be valuable. It's those more complex procedures. But I'm really encouraged by what we're seeing kind of in our own research and elsewhere, that the ease of use is really improving to a point where, particularly if you're going into the CT, you may be able to just choose between the two based on kind of personal preference. And certainly when it's a more complex case, when it's a smaller lesion and harder to visualize, you're going to go for that MRI.
I think that's a great point too, because I think really the MRI is not replacing what we're already doing with ultrasound and CT. It's opening up doors for those patients that were either impossible or really hard with ultrasound or CT. And so we shouldn't look at it as, oh, well, this is going to do it. No, it's not going to do everything, but it will do some things much better. And so, just like we talked about, it's the reason we don't have one catheter in the cabinet. We have a catheter for the right situation. So now we're developing an imaging tool, an imaging and an intervention platform that's going to be the right answer for the right patient.
And I think that maps to all of the other imaging modes as well. I mean, you're not running your primary catheter work in a CT, and you're not doing the majority of your needle targeting in a fluoro suite. You're matching the needs for that procedure with the imaging mode. And this is giving another really compelling imaging mode for a number of cases, but absolutely not all of them.
Yeah, it's a great point. And, I'll digress for a second where, I think we as IRs, we tend to be I don't know, for lack of a better way to put it, ablationists or, transarterialists kind of, right? Or Wynandius or whatever you want to say, right? And I think we as a community don't always do the best job of right therapy for the right lesion in the right patient, and these are the kind of advances and innovations in technology that allow us to do that. Every patient should not get one. Every patient should not get microwave, right? There are variations to this algorithm, and now it's incumbent on us to optimize the algorithm for the patient, right? So great points, both of you. So when you look locally, I think one of the things that has really struck me as important, this is very different than a CT service line, right? So walk me through manipulating the images, changing your orthogonal planes in real time. And how do you do that? You're not doing that table side, correct? So how do you do that?
Let me tackle that in the research setting with some of the real-time sequences. So you're working with a really good iMRI technician. And I think similar to choosing the right imaging mode, you're choosing the right images for that moment. So we think about planning, pre, peri, and post. And as we do our planning images, you're in an MRI. So you're going to get a diagnostic quality MRI. And you're going to plan off of that very high resolution image that takes maybe a couple minutes to acquire. But then you can step into, needle transit or targeting at a high frame rate, back off the spatial and the contrast resolution just a little bit, but get yourself very close, very quickly, avoiding structures that need to be avoided, avoiding those sensitive structures, and moving to the correct location based on that planning image in concert with that iMRI technician. And then depending on what you're doing, stepping into an imaging mode. If you're running ablation, are you acquiring every 4 seconds, every 6 seconds, every 8 seconds to get an updated picture of that ablation zone, either in cryo or thermometry? Or if you're taking a biopsy, take 20 seconds, do a really high quality verification image showing exactly where that tray is. It really is a little bit of a choose your own adventure. You can go from 15 frames a second to a 15-minute acquisition and almost everything in between. And I think this is something really exciting about this space from a workflow perspective. You get the opportunity to slow down and say, what is the thing that I need the most in this step of the procedure? And the MR can deliver that. Under Dr. Woodrum, I'm assuming that resonates, but wonder what your thoughts are.
Well, so I think the combination of the low field MRI and the increased access to the patient with the larger bore, I think opens up a fantastic arena of utilization of the live image. I'll be honest, my current state of what I do interventional MR right now on a daily basis, it looks very much like CT intervention. So a very stepwise, move the patient in, scan, quick scan, 20 seconds, but nonetheless scan, and then pull the patient back, manipulate the needles, and so forth. Where in my current work environment, where I use the multiplanar aspects of MRI is when I'm doing ablation monitoring. And so that is where typically, like most radiologists and interventionalists, I think in axial. So I tend to lean on axial images very heavily for getting my needle in place, even if it's off plane, but still nonetheless. And so, but when I'm monitoring the ablation, having a sagittal, coronal, or double oblique for looking at how close am I to that critical structure, that's huge. That's really big. And I'm getting that in real time. What do I mean by real time? I mean 20 seconds or less.
Got it. Well, I'm going to sidestep real quick, the comment about, thinking in axial imaging, because I'm the same. And a lot of my fellows will like to show me coronal imaging, with a new consult. And I can't think in coronal imaging. It's very hard for me, right? So I always divert back to the actual imaging. But anyway, I think your point is well taken. I mean, so clearly you have an MR technologist or an MR physicist outside the room that is manipulating the images in live time for some of these applications, right? And then you are in constant communication from inside the room to outside the room to do that, right? So there is a communication aspect to this. There is an aspect where you have a, I don't want to say second in command, but, colleague outside the room that is actively helping you guide your intervention, again, in real time, right? So I think that's the understated part to me that is also very different from CT, right? Because we don't rely on that as much in CT. When I'm using CT fluoro, I'm operating everything table side for the most part. And it's really just when I need a spiral CT that I'll call my CT technologist back over to get the next sequence of images, right? So this is a little bit of a departure from that and lends itself to the fact that it needs to be an iMRI team and not just the iMRI, IR or interventionalist that's doing the intervention, correct?
Correct. And I think that's a huge part as far as efficiency too. What I find in my cases now, I've got a team that's been with me a long time. They know what I'm going to ask for before I'm asking for it, and it's kind of like when you have that fantastic tech in the fluoro suite that's handing you the catheter before you're asking for that catheter. They know what you're going to ask for next. And so that's the feel. And I think that comes with experience. We all have experienced that at some level. And so as you get a team together and work with them, that does come with time. And that's truly where your efficiency becomes real at that point.
Yeah, that's a great point. And, we are not, interventionalists are not patient, right? And so, that is, I feel that in the angio suite. I'm down at UAB and, my technologists are phenomenal, right? And that's what I have. I've been down there in my role for about 9 months now, and I have, my technologist that will, give me the microcatheter or the microwire that I want. They'll give me the base catheter. I'm not asking for things, and that's a wonderful feeling. And obviously that translates to other service lines within IR. So, all right, I want to end on two quick questions here. So one, will we ever see an angio low field MRI combination unit? And then number two, what are the possible transvascular IR applications, right? There is old literature on tips in an iMRI. There's old literature on MR angiography with from a catheter, a selective catheter placement. Where we as IRs are obviously behind cardiology in the interventional MR space, but where is that going to go? Where's the transvascular side going to go?
I'm going to jump first on this one. So I think we will see MR-guided transcatheter work inside the MRI. And I love that you asked for the fluoro combo MR suite. I think it's what we need and what we've got to have. It may not be a full fluoro like what we're used to having in our fluoro suite, but nonetheless, if we're going to do real catheter-based procedures where we may get into trouble, we need a fallback very quickly into fluoro so that we can get ourselves out of trouble. And I think we got to push for that. But, to your point, I think what the catheter-based procedures in the MR can do is, again, open up those really hard procedures, okay? TIPS, they've talked about it, and it's kind of cool because you can see it so well. But I think further than that, think about some of your very difficult venous recanalizations where you're in fluoro and you're going, okay, am I in the vessel or am I outside the vessel? Because I'm trying to reconnect these two vessels together and I don't know. And it's really hard. I think it would be 100 times easier with the MRI. You would be able to see what you're doing, where you're doing it, and you'd be able to confirm that before you laid all the metal stents down going, I hope this is good. Yes.
Great point. Joshua, what about you?
I think this is just a really big open question right now, and I'll give kind of my personal thoughts on this, and I'll maybe step back and speak a little bit about the physics and the imaging. If I think about spatial contrast and temporal resolution as kind of sliders, fluoro offers us really good spatial, really good temporal, at the cost of contrast. We step into the MRI and I get to play with all of those to varying amounts, but I can't turn them all to maximum. There's trade-offs around this. And so very fine navigation in moving structures up in the liver, honestly, still a challenge. If you're in non-moving structures, a little bit easier. You can use time of flight to get roadmaps without contrast. There are some neat things you can do there. But that general navigation, I think, is still, it's a little bit slower than in fluoro. As we get into seeing the tissue itself, and I think the recanalization is a really interesting example. I think about it in terms of what is that clinical need there. If I need to see the tissue structures that I'm trying to cross through, trying to ensure I'm still in, that's an interesting example. I think the other one that is there is the delivery of therapies and understanding where those therapies go in 3D in real time or in near real time.
You're talking transarterially, right?
Yeah. And so, I think there's already talk around that with some of the holmium work being done over in Europe. And there are a host of other things that if it's really important to see that move through 3D, that volumetric understanding, volumetric dosimetry of therapies, or watching something injected into the arteries like a sclerosant or like an embolic, understanding that it goes this far and no further. You can do that in 3D in the MRI in a way that's not possible under other modes. And so those are the areas that I personally am interested to explore a little bit more. And I've seen other people, looking in those spaces as well.
Yeah. Well, and I guess theoretically, almost like watching a lesion be devascularized in the liver in real time, something along those lines, right? Which I know is a little speculative at this point, but would be fascinating to see. And again, innovation and next evolution of our therapies. Well, gentlemen, I appreciate both of your time, late on a Monday. I appreciate both of your candor. I mean, this has been an amazing conversation in a truly innovative space in IR. And obviously, we, sense both of your passion for it. So thank you for sharing. Any last comments?
I think the interventional MR opens up a completely new arena. And so I'm excited for our young fellows coming through as it offers an arena for them to reach out into. Yeah, just like you were talking about, they're talking about coronal and sagittal images. This offers that opportunity. We trained in axial. We didn't train in coronal and sagittal. We don't use them as much. But the next generation of fellows and residents coming through, they think about things in a very different way. And I think this offers some opportunities for them to really kind of change the landscape.
Great point. It's I feel like it's a little bit like, maybe my niece that can operate an iPhone, faster than I can, right? Something along those lines.
Exactly.
Well, I appreciate it. Joshua, any last words?
I think this is just a really incredible space. I've not been in it for quite as long. I've been working in this space for about 4 or 5 years now, but it is uniquely collaborative and open space. And I'm seeing that in collaboration across specialties, collaboration between companies, always collaboration with companies and physicians, but really people seeing the potential value, the potential increase in clinical confidence that can come from this, and the safety that comes from something that doesn't have ionizing radiation. And as people are interested in collaborating in this space, there's a really great community around this. And I would just urge them to be a part of that community.
Great point. And no matter what, you've been in this space longer than I have. Well, both of you have. So I'm relying on both of you for guidance. So, well, gentlemen, I appreciate all the time, and thanks for sharing. And I'm sure our listeners will enjoy the topic. So thank you again.
Thank you for having us.
Thank you so much.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at BackTable Innovation on Instagram, LinkedIn, or Twitter. BackTable Innovation is produced and hosted by Brian Hartley,
Aaron Fritz,
Diana Velasquez-Pimentel,
and Eric Amaker.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang.
Administrative support provided by Jimmy Willie Kennebrew.
Thanks again for listening.
See you again next week.